Hello, I'm David Bull. I'm a medical doctor and a journalist. We are at the 2018 American Heart Association annual meeting here in a very chilly Chicago. And I am delighted to welcome you to our TV debate on difficult to treat hypertension, new opportunities. And I have a fabulous group of guests that I have to introduce you to now. First up, Keith Ferdinand. Now, Keith is Professor of Medicine at the Tulane University School of Medicine in New Orleans. Joining him is George Baccaris. He is Professor of Medicine and Director of the Comprehensive Hypertension Center here in Chicago. And last, but by no means least, cardiologist and Chief Medical Officer of Quantum Genomics. And he is here because of a new study called the New Hope study in which he was involved. So let's start by talking about the unmet needs in hypertension. So to kick us off, here is a video message from Professor Jean-Jacques Morat.
High blood pressure is the leading cause of death in the world, and it's clear that despite 50 years of drug development, there are still needs in this area, even though the general impression is that this is no longer a problem. Indeed, at best, there's barely 1 out of 2 hypertensives in the world that benefits from the control of this risk factor.
Du contrôle de ce facteur de risque.
Well, gentlemen, very good to see you all. Thank you very much indeed for coming in. So let's start by talking about the disease burden attributable to arterial hypertension. And Keith, perhaps I could start with you, put you on the firing line. So basically, we know that patients with arterial hypertension are at risk of cardiovascular disease. So let's talk about that. Let's talk about, in particular, their cardiovascular risk, the cardiovascular events, and indeed cardiovascular death.
Well, you know, the problem is there are many risk factors. And right now there's a lot of interest in lipids because we have the PCSK9 inhibitors and some new medical models that are coming out how to treat lipids. But if you look at all over cardiovascular disease, hypertension is the most powerful risk factor throughout the world. If you look at heart failure, most of the patients who come in with heart failure, hypertension, chronic kidney disease with comorbid diabetes, even heart attacks, at least 50% of the risk for myocardial infarction is related to hypertension. So it's considered the #1 risk factor. It's common across all populations throughout the world. It continues to increase, and it's directly related to age. So in those societies that are getting older, the burden of hypertension will increase.
Okay, so now that we've woken up to the fact that hypertension really is such an important risk factor, as you say, and we as physicians major a great deal saying, well, actually, we need to talk about lifestyle changes, and then we need to put you on the appropriate antihypertensive. Just tell me, how significant is the reduction in blood pressure when you do that, when you do actually deal with those lifestyle risk factors, when you put them on the right antihypertensives?
If you look at lifestyle, it's the bedrock for the treatment of hypertension. Especially younger persons, they may be able to prevent progression of hypertension by decreasing sodium, excess body weight loss, physical activity, no smoking, reducing stress. That being said, the blood vessels actually remodel, they get thicker. And when a person's in their 50s or 60s and their systolic blood pressure is 150, 160 millimeters of mercury, they're not going to lifestyle their way away. At that time, medications are needed. And I think it's a mistake for patients who have definite hypertension, significant hypertension, systolic blood pressure 155, 160. Don't abandon lifestyle, but those patients need medications.
Okay, that's really interesting. In fact, George, perhaps you could pick up on this because, you know, in terms of which patients should we be treating, because certainly in the 25 years since I graduated, it's changed in terms of who should we be treating and what is the criteria now?
Well, I think clearly you have to focus, as Keith said, on what is their cardiovascular risk. And in fact, the new guidelines talk about greater than 10% 10-year cardiovascular risk. Those people you need to be very aggressive with. And you need to make sure that either their blood pressure stays below 130/80 if it's coming up, if they're younger, or if they're older, try to get it below 130/80 because that risk is going to come back and get them for the same reasons Keith was talking about. So you need to really have a range. It's no longer the laissez-faire of 150, 160. Well, think about it. No. It's gone beyond
I mean,
that.
I was going to say, because we were always taught about a diastolic of 100, and it was the systolic was 100 plus 1 for every year you were.
Yeah.
So this is a major change.
Those rules have changed. I mean, first of all, major point, we know now that if you're over 50, it's all about the systolic blood pressure, and you want to get that number controlled. If you're younger than 50, then it's about the diastolic pressure.
Okay.
And so a lot of people have gotten so focused on the systolic pressure that younger people that are in their 30s and 40s with systolics of 135, but their diastolic's 100, 110, they're okay. No, they're not okay. You have to look at both.
Okay, so now we've basically realised that hypertension is very important. We obviously have to be far more draconian in those people that we're treating. So let's talk about those people who are difficult to treat. So difficult to treat hypertensives. So what percent of patients, and perhaps George you could pick up on this, what percentage of patients do not fall into the groups that you want them to? So, yeah, what percentage?
So there's no actually good epidemiology on this. There's some guesstimates. But if you really talk about the person that's difficult to treat, these are the people that either don't want to take medicines, or they'll take some of their medicines, or they can't take medicines because they're allergic, or they think they're allergic. There's a whole variety of things. They're depressed, so they really aren't. There's a myriad of issues, and I would guess at least those are the people referred to me. So the people I'm seeing, probably 35, 40% fit that. I don't think it's that
as high as 40%.
Well, that's a selection bias because of the people I'm seeing. But if you actually look at the general population, it's got to at least be 20 to 25%.
What about for you, Keith?
I think that's about right. Now, George is a hypertension specialist and a nephrologist, so he sees patients, almost all of them have some degree of chronic kidney disease, and those patients are, quote, difficult to treat. If you look at the general population, most of the surveys say anywhere from 10 to 15%. If you look at the hypertensive population in a medical clinic setting, it may be as high as 20 to 25%. The secret is to identify what is that patient's risk. And that's what George was talking about. You put in their age. In the United States, we put in sex, race, cholesterol, smoking, diabetes, yes or no, blood pressure, and whether the person's on medicines, and then we calculate the risk. So we don't just go on the number, it's also related to risk. And remember, age is probably the most powerful risk factor of all.
Okay, I was just going to bring you in, Bruno, here, because obviously we've talked about all these various risk factors, but also as a cardiologist, you've prescribed a lot of antihypertensives. Compliance must come into this as well in difficult to treat patients, or lack of compliance, because it's tricky taking medication.
Yeah. It's very, as you said, compliance and we say now adherence is a major concern, whatever the pathology. And interestingly, this is not because a disease is severe that compliance or adherence is better. But in hypertension, this is also another story, because indeed the patient do not feel sick at all. So they are really able to forget the drug, and we ask them to take the drug every day, and sometimes with side effect, and they don't feel sick. So this is indeed a major concern.
Yes.
You know, we used to call it the silent killer, because the patient can have significant elevated blood pressure, target organ damage, heart disease, chronic kidney disease, and, quote, feel okay. But now there's some studies that those persons, especially with more severe forms of hypertension, when you treat them, they feel better.
Is that right?
So they may not have really bad symptoms, but there are symptoms. They're
enough.
tired, fatigue, exercise intolerance, and they actually feel better.
Well, just to corroborate that, I will tell you anecdotally, but from numerous patients that I see who are coming all uncontrolled, we get them controlled, and we reduce the sodium in their diet. And many of them come back and they're telling me, for the first time in their life, for many years, they're able to sleep through the whole night and not get up, and they're feeling more rested in the morning. Because when you lay down, your pressure's even higher. So it's really important.
So let me just bring you back to these difficult to treat hypertensives. So in terms of those, what are their risk factors at this point? How bad is their risk?
Well, we're going to talk about the United States because that's where I practice.
Sure.
Age is a powerful risk factor. Older persons with hypertension, it's more difficult to treat. They have more left ventricular hypertrophy, more chronic kidney disease. Diabetes is a risk factor. Diabetes goes along with chronic kidney disease. And many patients with chronic kidney disease have a salt-dependent volume hypertensive, and if it's not treated appropriately, it won't lower. Being of African descent in the United States, African Americans have more hypertension, comes earlier, more severe, and more difficult to treat. But you know, we don't really know if that's genetics.
So I was just going to ask
that could be an epiphenomenon.
Well, I was just going to say, why is that? So we do see that. So particularly in black people, they are more difficult to treat. Why?
But that may not be genetics. Now, there may be some genetics related to chronic kidney disease, and we say chronic kidney disease is a factor. But let's take that off the table. Most of the patients is probably related to a high sodium diet, high saturated fat, physical inactivity, and psychosocial stress. We call it in the United States the social determinants of health. Where you live, where you play, where you eat, what you eat, have a great impact on your blood pressure.
And would that also sort of be one of the reasons why not only is it difficult to treat, they're not very responsive, they have high morbidity, high mortality, and many drugs don't work? That's the bit I don't get, that certain classes of drugs don't work on the black population.
Well, I've done a lot of trials, and George has also, and we know that monotherapy or first step therapy with ACE inhibitors and angiotensin receptor blockers called ARBs tend to be less effective in blacks. And that might be because they're less effective in persons who have low renin hypertension, salt-sensitive hypertension, obesity, stress-related. Those patients may respond less. And then we don't control for those factors, and we say, well, the person's self-identified black, so it must be because they're black. But it could be the other factors.
Okay.
I mean, I just to add to that, it's very clear that African Americans are very salt sensitive, and you'd be amazed in the patients that actually do follow the adherence to a low sodium diet by itself, the drama that I've seen in terms of lowering blood pressure, much more dramatic than I have in Caucasians.
Right.
So there really is something going on at the vascular level with nitric oxide and other things that is influenced by salt.
So can I just bring you back to this idea of secondary causes of hypertension? I'm talking about things like kidney disease, which you mentioned earlier on, about endocrine disorders and so on. In this population of difficult to treat hypertensives, what percentage do they make up?
You'd be surprised. It was largely felt for many years that many African Americans don't get primary hyperaldosteronism, that's really more a disease of Caucasians. Turns out they don't get it because we never checked. When you check, guess what? They get it.
But you're not talking about an adenoma or a tumor.
Right.
These patients could just have hyperplasia or overactive aldosterone.
Which is more common.
Yeah.
That's more common. So the bottom line is a lot of blacks are known to have low potassiums, and they just figure, well, you're eating too much salt, you're taking diuretics. And that's not true in many of them, because they actually do have primary. I've got a whole cadre of them in my clinic referred because they didn't know what to do with them, and all we did is a simple diagnostic evaluation. So it's much more common than appreciated.
How interesting.
I just diagnosed some patients who have identifiable, we often use the term identifiable because you find something, you identify it. So secondary, identifiable. But patients who have identifiable hypertension who have been carried for years and unknown. So there are other factors that come into play, and that's why we know that some of the patients have hyperaldosteronism, may not have a tumor. That's why I was saying to George, you're not necessarily talking about imaging and finding something, but if you do an aldosterone renin level, you check the urine potassium, you find out that the patient really does have excess in aldosterone.
Okay, so let me just ask all three of you, actually. So what do we mean by resistant hypertension?
Well, the definition of resistant hypertension, per the current consensus update report that I was part of writing, basically is simple. You are on 3 complementary mechanism medications, so diuretic of some type, thiazide usually, calcium antagonist, and a blocker of the renin-angiotensin system, and you're appropriately dosed at maximal tolerated dose, and in spite of that, your blood pressure is now above 130/80. That's the American guideline. The European guideline is 140/90, but it doesn't matter. You're not at goal.
Right.
That's the point.
Okay, and what's the prevalence of that in African American community?
Much higher.
Yeah.
Much higher. It's
How much higher?
Oh, could be as high as 20%.
Really?
And if you look at the general population, it may be 10%, but it's significant.
And what about in obese patients generally?
Obesity is clearly a marker, and that might be a marker also for more salt sensitivity. Right. Salt sensitivity meaning if the person consumes a sodium load, the blood pressure elevates more. But many patients, especially in the United States, who have African descent, they live in the Southeast, they have diets with more sodium than you could ever imagine. I mean...
No, this is true.
Yeah, no, I'm sure it is.
And case incidence of obesity is more important in Black as well?
Well, in general, in the United States, it's increasing, about 39, 40%. Yeah. But in African Americans and Hispanics, in the minority populations, the rates of obesity are higher, and that's another marker for resistant hypertension. So salt sensitivity, resistant hypertension, obesity, racial ethnic minorities, it kind of hodgepodge. They come together.
So from what you've all been saying, it seems very clear that actually for many of these patients there are specific needs not being met, that for many of these people that hypertension is a disease that really isn't massively under control. And I suppose, Bruno, for you that's an exciting challenge, some opportunities there for you particularly.
Yeah, that's true. Indeed, there are a lot of drugs on the market to treat hypertension, but despite this drug, all the patients are not controlled. So it's really interesting and important to try to find out new classes of drugs, because we have a lot of classes, but we need some more. And the reason why is also because very often, and now it's in the European and American recommendation guidelines, to start with two drugs, with B therapy with two drugs, and a lot of patients are treated with 2 or 3 different drugs, and so that's why we need new classes to combine with the existing class.
Yeah. Well, that is a very good moment just to pause things. Now, Bruno, I know that you're going to pop off, but you'll be back to join us a little later on. And whilst you do that, now let's talk about the mechanisms of difficult to treat hypertension and, of course, the new opportunities. So here's a video report from Professor Jacques Blacher.
I think it is very important to point out the fact that resistant hypertension is not an homogeneous disease. There are many different patients who present resistant hypertension. Some patients will have hypertension difficult to treat because they eat a lot of salt, others because they are obese or overweight, others because they do not take their drugs. It's an important phenomenon. Others because they drink too much alcohol. And again, it's not only a pharmacological problem, but we know that in some patients we need to add different drugs, and sometimes to add 3, 4, 5, 6, 7 different types of drugs for those patients. And if we do that, we finally control their hypertension. And then, if there is a new class coming on the market, we specialists of hypertension are very happy, because we know that we will control more patients, not all of course, but perhaps a small part of all the patients with resistant hypertension. Then we will take this new as a very good news that there is a new class of drugs in hypertension.
Well, I'm delighted now to introduce Fabrice Ballavoine. And Fabrice is Vice President of Research and Development of Quantum Genomics. Now, I'm particularly thrilled that you're here, actually, because you've worked on the new mechanisms involved in the treatment of difficult-to-treat hypertension. But before we come to you, perhaps I can go to you, George, and say, let's just talk about those classical mechanisms involved in difficult-to-treat hypertension. Can you give us a recap?
So basically, if you look at the systems in the body, there's the renin-angiotensin system, which everybody gloms onto, and that's a key system that is involved with especially certain types of hypertension. There's the sympathetic nervous system, which is definitely involved in a specific kind of hypertension as well. That's central, more centrally mediated. And then you have the whole issue of the kidney, sodium handling, and other hormones related to that, one of which nobody really appreciates, is vasopressin. But there's really nothing that is, because there's different kinds of vasopressin receptors, and the V1 receptors are the ones that affect pressure. Everybody thinks of V2 receptors because that's what vasopressin handles water.
Right.
That's a totally separate issue. It has nothing to do with blood pressure. So the V1 receptors are important, and they're in the periphery and central.
So Keith, looking forward then, so those are the classical mechanisms. Are there newer things on the horizon? And particularly you mentioned the renin, angiotensin, aldosterone system there. For my memory, peripheral, are there, and that's a leading question to say, are there then some new innovations and new exciting things that we should be looking for?
Yeah, I'm very pleased to be the principal investigator of a new trial using an aminopeptidase A inhibitor that works centrally to block the conversion of angiotensin II to angiotensin III, and it does affect vasopressin release. It also blocks sympathetic activity and increases baroreceptor activity, all of which potentially will lead to a decrease in blood pressure.
Okay, I'm going to bring Fabrice in now. Okay, so tell me about aminopeptidase A. Where is it? What does it do?
Yeah, so aminopeptidase A, as Keith mentioned as well, it's a major enzyme of the renin-angiotensin system. It is the enzyme that cleaves angiotensin II, the aspartic residue of angiotensin II, and convert it into angiotensin III. It's aminopeptidase A because A is for acid residue. So it's not only cleaving the angiotensin II, but other natural peptides.
Okay,
but
and am I right in thinking this is in the brain though?
No, it's not only in the brain. It is in the brain, but also located in the intestinal and renal epithelial cell, in the endothelium also.
Okay, so the next question then, if you're stopping the conversion of angiotensin II to angiotensin III, why would you want to do that? And wouldn't you get nasty side effects as a result?
Well, we are targeting at Quantum Genomics. We develop a new class of drug called brain aminopeptidase A. So we are really targeting the enzyme at the brain level, because in many hypertensive models, at least in animals, there's an overactivation of this enzyme, overactivation of this brain renin-angiotensin system that contribute to some of the pathways that George mentioned. And we, by designing this new drug called ferribastat that was evaluated in our New Hope study, we are really normalizing the activity of APA to normal level and in a way inducing a control.
So ferribastat is first in class, isn't it?
Yes, ferribastat is the first drug candidate and the first in class molecule.
I was going to say, it's also caused quite a stir here at the American Association as well. So tell us then about that. So,
well, this work comes originally from France. It comes from the work of Catherine Lorenz-Cortez, who is a neurobiologist in France. She worked on the biology of angiotensin III and really characterized the role of angiotensin III at the brain level. And so the ferribastat is really targeting APA, aminopeptidase A, at the brain level to prevent the production of angiotensin III. And by doing so, it occurs a triple mechanism of action that reduce the release of vasopressin, that reduce the sympathetic tone, and that activate the baroreflex.
So just to get this absolutely clear, ferribastat works in a completely different way to, say, something like an ACE inhibitor.
Right. ACE inhibitors, classical ACE inhibitors, are not brain penetrating for most of them. Perindopril, captopril, maybe to a less extent, can penetrate into the brain, but most of them are not penetrating into the brain. So let's say the classical RAS, the RAS is a renin-angiotensin system, I must say. The main effective peptide is angiotensin II, and it has been worked for years. So ACE inhibitors are inhibiting the production of angiotensin II. ARBs are inhibiting the action of angiotensin II. Ferribastat, brain aminopeptidase A inhibitors, are blocking brain angiotensin III, which is the main effective peptide of the brain renin-angiotensin system. Just let's say, an ACE inhibit an ACE at the periphery. Sorry.
Okay, so just giving some clinical relevance to this, you talked a great deal about salt earlier on. Firebastat, how does that work? How does it work in terms of salt-induced hypertension?
Well, yeah. The animal models suggested that.
Animal models.
Yeah.
We're in our animal studies, we've seen that firebastat is more effective in salt-dependent hypertension models, which is the docosalt rat. So in docosalt rat, the renin-angiotensin system, the classical one, is depressed, and it, in a way, classical RAS blocker are not working well in this model. Firebastat, our new molecule, is very more potent and more potent than in SHR, which is a model of essential hypertension.
So Keith, does that excite you?
Well, it does. That's why we did the study. We really didn't know. There was a pilot study, a phase 2A, small study, 34 patients in Paris, that had shown some blood pressure lowering. And in normal tenses, really no effect. So the hypothesis is if you have a population that mirrors what a docosat rat model would be, that is a salt-sensitive, low renin, sympathetic drive, obesity, that perhaps this drug would be effective.
Yeah, so it is very exciting.
It is, and it is a great moment to present at AHA these results of our phase 2 study.
So just let me ask you some questions then about firebastat. What's the half-life?
Half-life is actually quite short, and this is why we design a protocol with a twice-a-day regime in our study. But we are working, obviously, because compliance, adherence, and most of the antihypertensive drugs are once-a-day formulation. We're working on slow-release tablet formulation.
Okay.
And we will, in next year, well, in early 2019, begin a new study to really identify and select this new tablet slow-release formulation to be used as a once-a-day tablet.
Which will be much better for the patient.
Yeah.
And what about the use of firebastat for patients with heart failure?
Well, we have also, in heart failure models, the brain renin-angiotensin system is also activated, overactivated, and we have very promising data in a model of in rodent following myocardial infarction, where firebastat was shown to improve the left ventricular end diastolic pressure, improve ejection fraction, but interestingly, without lowering blood pressure. And this is very interesting because in these patients in heart failures, sometimes blood pressure is low. Most of the drugs are affecting blood pressure, and they cannot be, for some patients, titrated to the target dose. And so with firebastat, we have a very promising drug also for heart failure. We will initiate a study next year in post-MI in left ventricle dysfunction following myocardial infarction. And I guess Bruno, our Chief Medical Officer, can comment that further then.
Fantastic.
Later.
Well, he is coming back in just a minute. Thank you very much indeed, Fabrice, for telling us all about that. Well, let's now talk about the perspectives of this new drug with a video report from Professor Gilles Montalesco.
We have just had the results of the New Hope study, and it's quite interesting because with this first-in-class drug, we have a beautiful effect on blood pressure in these hypertensive patients, obese patients, and clearly this is really a new mechanistic action that we have to control blood pressure. Knowing also this mechanistic effect, we may wonder if this type of drug could have other targets. And I think we should think of different type of patients. Congestive heart failure patients is probably one good target for this class of drug. And possibly also post-MI heart failure or post-MI patients at risk of heart failure, because obviously we would expect a benefit on the preservation of left ventricular function, but also probably an effect on fibrosis. So the whole remodeling process may be impacted favorably by this type of drug. So this is probably new targets for the next studies, and maybe new hope also for the coronary patients.
Very good to see you back, Bruno. And just to remind you that Bruno is Chief Medical Officer of Quantum Genomics, and he's here because of a new study called New Hope, of which you were very involved. So can we start by asking you, what was the design of the New Hope study? How many patients? What kind of patients?
So first of all, we are very, very proud to present the result at the AHA for a French biotech company. It's a huge thing. The New Hope study is a multi-center study that we conducted in the US, and Keith is the PI, the principal investigator of the study. We wanted to enroll in this study the population we just discussed about, difficult to treat patients. That's why we have chosen to recruit hypertensive patients, all overweight or obese, and with a target to enroll at least 50% of patients coming from minorities, so Black or Hispanic patients. And we have enrolled 256 patients into the trial. The primary endpoint, so what we want to demonstrate is a decrease in office systolic blood pressure, automated systolic blood pressure, after 8 weeks of treatment with viribatide.
Okay, and how did you assess the blood pressure in the study?
So this is a very interesting debate. We have chosen to assess blood pressure by what we call automated office blood pressure. So it's quite simple. The patient is left alone in a room, seated, quiet, and the device takes automatically 6 measurements, and we average the 5 last measurements.
Okay, so the idea being that you remove white coat hypertension?
Yes, and it has been shown to be very close to the ambulatory blood pressure measurement.
Okay, so tell me the results that you presented here at the AHA in Chicago. What results did you present?
So we, indeed Keith presented the result here. We have demonstrated a decrease in systolic blood pressure by 9.7 millimeters of mercury, which seems to be it's highly significant from a statistical point of view, but it's also clinically relevant because when we designed the study, we have powered the study to show a minimum difference of 7 millimeters of mercury. That was discussed and thought together with the steering committee to be clinically relevant in such a high-risk, difficult to treat population, and we exceed this goal. So.
Okay, so you presented it. How did you feel presenting it? I mean, is this a good result?
It was a very good result. You're looking at a population, the overweight and obese, the BMI was 33, the mean BMI. The blood pressures were averaging 154, which is quite high. It's close to what we call a stage 2 hypertensive population. Mm-hmm. There were 27% persons with diabetes. The median age was 58. There were about 27% who were over the age of 65. So these were middle age and older, obese patients, many of whom had diabetes with significant hypertension. These weren't the little mild hypertensive patients that I've done in some other studies where we want to just lower the blood pressure a few points. These were patients who had robust blood pressure at baseline.
Right, okay. So that 9.7 that you talked about, that decrease, what does that mean in terms of reduction of cardiovascular events?
Well, we really don't know. It wasn't a cardiovascular outcomes study, but the FDA now says that if you appropriately lower blood pressure, it could be what's called a surrogate for cardiovascular risk reduction. And we think that for every 3 millimeters of mercury, you're going to get about a 20-25% risk reduction. So this may cut in half the risk of having a major cardiovascular event. But it was not a cardiovascular outcomes. It was a safety and efficacy study, and we're just using blood pressure here as a surrogate.
So you need an outcome study?
Not necessarily. The FDA actually says that because there have been so many studies that have consistently shown that blood pressure reduction lowers risk, that you really don't have to do a placebo-controlled cardiovascular outcomes trial in a blood pressure medication at this particular point. And in fact, one of the things Bruno and I discussed was that it may be difficult because we wanted to get the more severe patients. The physicians, the subjects probably wouldn't go for it if we tried to do a cardiovascular outcome study to see what happens. Who wants to be in that placebo group?
Right, okay. And how did the results translate into the subgroups? Particularly, we talked earlier about the black population and being difficult to treat.
Yeah, 37% were self-identified as black. They did just as well. In fact, they did a little bit better. They had the same blood pressure reduction. And with ACE and ARBs, we didn't see that. I was on the Data and Safety Monitoring Board for ALLHAT. ALLHAT was the largest antihypertensive trial ever. And in that particular population, lisinopril-based therapy as a first step had 3 millimeters of mercury higher blood pressure than chlorothalidone, diuretic-based therapy. And in that particular trial, which was an outcomes trial, there was a 40% increase in stroke in the black patients. So those small differences in blood pressure, higher blood pressure with the ACE inhibitor translated into more strokes and less protection against heart failure, even though it was a RAS blocking agent. So again, this trial was not a cardiovascular outcomes trial, but we're looking at a surrogate, and the technique that Bruno described, the automated blood pressure measurement using those 6 measurements and throwing out the first, is really a good surrogate for a blood pressure load, especially awake or daytime blood pressure.
Okay, let me ask you about side effects, Bruno. Were there any?
Of course, there are always side effects, but overall, the drug was firibastat was well tolerated. The most common side effects were headache, around 3%, and skin reaction, 4%, and this is more or less what happened with the other class of antihypertensive drug.
Okay, and what was the impact on patients' blood potassium?
So we had no impact on blood potassium, and I think this is really important because diuretics, for instance, decrease potassium blood level, and ACE inhibitors and ARBs sometimes increase potassium blood level. So because we are neutral on the potassium, we may be combined with any of these drugs.
Okay, and perhaps I could ask you then, what was the effect on the patient's hearts, kidneys?
Well, we didn't measure particular cardiovascular outcomes again,
No, sure.
but the GFR, the glomerular filtration rate, didn't change at all. No change. Now, these were 87.7 GFR, so there weren't people who had bad kidneys. In fact, we mandated that if your GFR was less than 45, you couldn't enter into the study. So 87 is basically normal kidney function, but there was no deterioration in GFR, no change in electrolytes, small increase in glucose, but that was within the variation that you'd see over a month in an obese population. There was really nothing in terms of metabolic derangements that was seen.
So just taking on board those results, how do you see them translating into patients who are difficult to treat, those difficult to treat hypertensives?
Well, Quantum Genomics is the company that owns the medication, so they would have to make decisions where they want to go next. I would think it may be something that you could add to a cocktail of medicines.
Yeah.
I'm from New Orleans, Louisiana, USA. We call it gumbo, where you put a little seafood, a little rice, a little okra,
salt,
you mix it up,
salt.
and some salt.
Yeah.
So they may want to add it to other medications to see if it has a better effect when you combine it.
Okay, so Bruno, what are the next steps for you for the development of the molecule?
So from the beginning, our strategy was to target difficult to treat or even resistant hypertension. So probably the next step will be to study firibastat in resistant hypertension. And indeed, this can be only on top of other drug, because in resistant hypertension, it's a combination.
Bruno, so earlier on, Fabrice sort of alluded to using firibastat for heart failure. So what about heart failure?
So heart failure is a very important axis of development for quantum genomics. As said by Fabrice, we've got very good results in both rats and mice following myocardial infarction. And we do believe that firibastat will be able to improve cardiac function in human as well. So that's why we will conduct very soon. We expect the first patient in beginning of next year, a clinical trial in heart failure called Quorum. And to be as close as possible as the animal models, we will study the drug in a patient following an acute myocardial infarction. And the patient will be treated for 3 months, and we will assess the cardiac function by MRI.
So this is very much the beginning. Are there any other molecules in development at this time?
Of course, we have a whole family of brain aminopeptidase A inhibitor, but firibastat is the first in class, and there are some other drugs behind, but at a very early stage of development.
If I've heard this correctly, it sounds to me like firibastat is really, in many ways, a game changer in these difficult to treat hypertensives. Is that accurate?
Potential. You know, this is the first study, first of its kind. It was a high-risk population, 50% minority, 37% African Americans, 27% diabetes. So these were really patients who needed to have a medication that lowers blood pressure effectively. I think we need to do more before we can use those terms, game changer. I think that's a little bit over the top.
Okay, can I use the word breakthrough? Bruno?
We do hope. We do.
Yeah, okay, fine. Okay, just to close this, so perhaps you could leave with, what is your one sort of take-home point from all of this? Bruno?
So I think for us, this was really a proof of concept that the drug works by targeting the brain to be able to decrease blood pressure. And also, there was a very good correlation and translation between our animal models and what we got here in the New Hope trial. And Fabrice spoke about DOCA, salt, and rats. And here we had the same efficacy in black versus non-black, in obese patients, which are very likely to be salt dependent. So it's very exciting for us to see that what we thought when we add the preclinical data in rats in the lab, now translate into human.
Okay, George?
I think this is exciting because it's the first new class of antihypertensive medication that has been developed since 2005. So that's a big deal. Number two, it could easily supplant commonly used drugs like clonidine and other agents that work centrally that have an overlapping mechanism but are clearly not tolerated by anybody, and be a nice adjunct to therapy, especially in the subsets that Keith was talking about. So I'm excited about it.
And Keith, I assume you are.
Oh, I'm very excited. In fact, the Association of Black Cardiologists collaborated with Quantum Genomics, sight unseen. I mean, these guys come from Paris with the funny accents, and we say, well, you know, it sounds like they have something to offer, so we collaborated with them. And clinical trials in the United States often underrepresent racial ethnic minorities, and here we got 50% and showed a benefit in blacks similar to non-blacks. So this was, in a way, a step forward just in the clinical trial design, that you didn't just get the nice little patients that are easy to treat, you got the more difficult to treat patients with a robust inclusion of racial ethnic minorities.
That's really fascinating. Well, gentlemen, thank you so much. I'm really sorry I'm going to have to draw it to a close, but I really do want to thank you for being such wonderful guests. And thank you for watching. We'll see you soon for another debate.